Hello everyone, welcome you all to the digital platform of the MNR hospitals. Myself, Dr. Shankar, consultant, urologist and andrologist, MNR Hospital, Sangareddy. Today I am here to share with you my experience with one of the complicated cases of chronic kidney disease with AV fistula. My patient, who was a 45-year male with a known case of chronic kidney disease with multiple attempts of AV fistula creation done by various surgeons at various centers, came to us for a AV fistula creation. On clinical examination, he had a failed fistula in the left hand at the elbow. Two fistulas were created which were failed. In the right hand, there was an attempt of radiocephalic fistula attempt at the mid forearm which again failed, and he had come with me with the option of creation of AV fistula at the right elbow. He is a right hand dominated person. On clinical examination, his right cephalic vein at the elbow would be around 1.25 to 1.5 mm in diameter, while his right brachial artery at the elbow was of normal caliber, normal flow without any evidence of any thrombus on clinical examination. We supplemented this examination with a color Doppler, and after tourniquet application, the right cephalic vein went up to 2 mm in diameter and the right brachial artery was normal. There were no thrombus in that. So after explaining the procedure and obtaining a proper consent, after explaining all the complications, we took the patient to the operation theatre. The cephalic vein was around 1.25 to 1.5 mm in diameter, while the brachial artery was of normal caliber without any evidence of thrombus. So we mobilized both the cephalic vein and the brachial artery, ligating the vessels of the cephalic vein and also ligating the branches of the cephalic vein and the branches of the brachial artery. We gave a nick over the cephalic vein, a good backflow of blood was present, and then we gave an incision over the brachial artery after applying bulldog clamps. Following this, we did a side-to-side anastomosis of the cephalic vein and brachial artery using a Prolene 60 suture, first completing the posterior wall, which will be followed by completion of the anterior wall. After the anastomosis, proper hemostasis was done, there was no further bleeding, and a good intraoperative thrill was present. After looking at the hemostasis, the wound was closed and the patient was shifted to post-op. On the post-operative day 1, the patient was well, the wound was fine, a good thrill was present, which was further supplemented with the color Doppler. In the color Doppler, the peak systolic volume in the vein was 150 centimeters per second and the end diastolic flow was 100 centimeters per second, which means a good blood flow across the fistula is present. And it is important to understand that these AV fistula are the life-saving procedures for these patients on CKD who require a regular dialysis and who are waiting for the transplants. And as in India, we don't have much of donors, so many of these patients lifelong they undergo dialysis and don't get a proper donor. So a proper patient selection and a proper technique remains the key to success for the AV fistula creation. Thank you all for your support. Thank you very much.